This week on the BackTable Podcast.
I think the key is knowing the appropriate intervention, whether that's IV antibiotics or surgery, as soon as possible. And then that's going to get them out of the hospital as soon as possible. But if it's a medial, 1.5 centimeter abscess, they may get better in 48 hours and they could go home. So you're optimizing the care and the timing of care by increasing your fundamental knowledge of what that abscess actually is. If they're sick, you're going to take them to the OR immediately anyway, and you're just going to treat them for sickness. So I think you just do the right thing for the patient, but using some of the data to determine the optimum kind of timing of care helps decrease the cost in general, and it improves the quality of care.
Hello, everyone, and welcome to the BackTable ENT Podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. My name is Gopi Shah. I'm a pediatric ENT, and I have an awesome guest today who is also a fellow pediatric ENT. I have Dr. John McClay. He's a pediatric ENT practicing at Cook Children's ENT in Frisco and Prosper, Texas, and he is here to talk to us about retropharyngeal abscess in children. Welcome to the show, John. How are you?
I'm doing great. It's great to see you, Gopi. It's been a while.
It has. I was going to say my first, memory of working with you was actually when I was a fellow at UT, and it was like early on, month one, and I think on a Monday we had a pretty extensive allergic fungal sinusitis in like a 10-year-old. And then that Wednesday, there was like a, open airway reconstruction with you. Like 3 days later, I'm like, man, he's got range.
Well, that's a good week. So,
it was a good week.
In fact, especially when you came through like 2013, 2014, because like airway was kind of drying up a little bit. I mean, we'd done a ton before, but people were taking care of them in a better way. I mean, they were using smaller tubes in the ICU, and so it was just better. So I love airway surgery and sinus surgery. Those are two big things for me versus the ears. I didn't do as much ear surgery. So when that kind of started decreasing, I was like, a little bit of a bummer, but happy for the kids. But I like the procedures. So that was good. But, I remember those cases, and I actually was happy when you decided to stay at UT because I was leaving and I did a lot of the sinus stuff there.
Yeah, no, I learned a ton. Because I remember being like, what? No, I need somebody to teach me.
Yeah, but you were already pretty good. So I was happy with your surgical skill set. And I thought, this is good that she's staying. And then you did kind of take over a lot of the airway, the cystic fibrosis kids.
Right.
Because we had operated on about 60 of them. And then we were finding out whether or not that was beneficial. But I was glad that you kind of took the reins because you were good.
Yeah, no, it was fun to build a sinus school-based practice at Children's and at UT and have people like Dr. Brett Markle, Dr. Matt Ryan to, work with. I would reach out to you because the hard part, the surgical skill's great, but the hard part eventually is like the decision-making, right? When to go back, revise. I think things are better definitely in our CF modulators now with some of the sinus disease as well as, with the biologics and things like that. But yeah, anyways, it was a fun time. I'm so glad you're here. Before we get into retropharyngeal abscesses, can you tell us a little bit about yourself and your practice?
Yeah, so we were talking about, that was 10, 12 years ago. And then, so I did leave the med school. I was there for 17 years. And then I decided to open up a practice in Frisco, but I still took care of a lot of sinus kids and some airway kids too. I did some airway surgeries at other hospitals and they were freaking out a little bit about that. But when I left, there was a clinically integrated network that was getting formed through Children's. And so I got involved with that. I was on the board and then I was the chairman of the quality committee actually. And so we thought, well, gosh, value-based medicine's coming in. Let's figure out what we can do to like save costs, but also increase the quality. But really, that kind of fizzled out after 5 or 6 years because insurance companies kind of cared about quality, but they really cared about cost. So we were doing all these things about measuring different quality, had different quality measurements, but didn't really matter much to them if we didn't save money. So anyway, I also was getting involved with American Academy of Pediatrics. I was on the executive committee for a while and then became the chairman of the education committee. And then actually I'm still doing that. So we're coming up with different and educational materials for pediatricians. So
That's awesome. I love that. Well, let's get into our topic today, a retropharyngeal abscess in children. How do these kids usually present to you?
Really like any neck abscess, whether it's retropharyngeal or lateral, whatever, they have neck stiffness, fever, sometimes neck swelling, depending on where the abscess is. They'll have odonophagia, dysphagia, and if they start, fever oftentimes, but if they start having issues with their airway or stridor or sternum, you get a little bit more concerned. So it's pretty typical with neck infections all over the place in the head and neck area. They present very similarly.
In terms of retropharyngeal abscess, I feel like it's usually in the ER or the inpatient setting where they've been admitted. Have you ever diagnosed or had a kid sent over to you in the outpatient setting with a concern for retropharyngeal abscess?
Well, usually we get the phone call and we say, maybe you should go to the ER. But sometimes somebody will, I've seen a couple kids, especially peritonsillar, probably more than like a retropharyngeal, and they'll come in and, it's a teenage kid. When I was training, we would drain those in the emergency room if they were like 14 to 18 or something, because they could tolerate it. But younger kids really don't. So, I'll see them in the clinic, but I won't do anything. Actually, I think when I first started, I probably tried to drain a couple and it wasn't very fun. So we just send them to the ER and kind of get a better diagnosis and then go from there.
In terms of like risk factors, do you feel like there's any specific risk factors? And the reason I ask is, sometimes families, when they come in and their kid does have, whether it's a peritonsillar or more so, though, I never know how to kind of answer when it's a retropharyngeal abscess of why this happened, what they could have prevented or avoided. How do you explain that to families? And are there risk factors that maybe I'm just not thinking about?
Well, really, it's a cold. Kids, when they get exposure, they get 10 or 12 colds in the first couple of years of life, right? So they're, especially if they're in daycare, but anytime you get exposure. So starts with upper respiratory tract infection, then leads to lymphadenitis, and then it leads to an abscess if it progresses. And those are usually kids from less than 6, 1 to 6 years of age. Now, older kids, if they've had dental problems or teeth that are hurting, but a lot of them too, it's an upper respiratory tract infection, or maybe for peritonsillar, it's, strep throat, recurrent strep throat. So, and when you look at different kinds of infections in different areas, now for retropharyngeal, it's pretty much an upper respiratory tract infection. But for older kids and lateral infections, it can be a dental issue.
Yeah, that's a good point. And I guess another thing to sometimes think about, which I don't think is common, is maybe like trauma. Or have you ever had a kid with a history of trauma, or even like potential foreign body, even though that, like a fishbone or something, even though that's going to be very rare, usually there's going to be a history associated.
I think I've seen one fishbone that caused a neck abscess. And trauma, you see that more in older kids that lead to an infection. A lot of kids, young kids will have trauma, like from a toothbrush or something. You always worry because the palate has a laceration. And if it's lateral, you got to get a CT scan to make sure their carotid's fine. But I don't know if I've ever seen a neck infection from trauma in a young kid. And I've seen a lot of trauma in the palate.
Yeah, no, that's a good point. In terms of like the younger kids, when I think of retropharyngeal abscess, I think of like 2 to 6. But then there are those handful of babies that will come in that are infants, like under, 15 months, that are under a year. Do you think about that group a little bit differently in terms of presentation, exam, or risk factors?
Yeah, I treat all neck abscesses the same in the sense that I look and see how sick they are, right? So if they don't seem very sick, I don't get as concerned, and sometimes I will treat, non-surgically. However, you're right. Those 18-month, less than 1, it's more often going to be like staph versus strep in those young kids. And, with MRSA too, even though we did a study, but that was probably about 15 years ago, that showed there wasn't increased complications with MRSA. You still kind of worry about that a little bit. So I do probably are more hypervigilant with a young kid, just because too, a little swelling and their airway smaller, they're going to lead to a problem quicker. And you don't know what their immune system's like, right? Your immune system doesn't get to where it should be until you're 6 or 7. And by 2.5 or 3, it's about 85% of what it should be. So on a 1-year-old or 18-month-old, their immune system's not great.
Yeah. Tell me about your exam. How do you go through your physical exam, and when is a scope indicated?
So, well, physical exam, certainly you're going to palpate the neck. You're going to look at them first and see how sick they look, right? And a young kid may look lethargic. And, you're going to see if they have fever. I guess you could feel them. You could tell if they have fever. Usually it's, documented. And then you can look in the pharynx, right, to see if there's swelling of the tonsils or if there's a bulge in the retropharynx, and palpate their neck. Now, it's interesting because for retropharyngeal, it's going to be a little bit different in the sense that you could get lateral extension, but probably not. You have neck stiffness, but the swelling's probably less. But if a child does have significant like left neck swelling and they've had it a couple of times, I remember this 8-year-old scoped her and saw pus coming from the left piriform sinus. So, in your differential of like a lateral neck infection, you have to think about a fourth branchial cleft cyst. And for some reason, we saw like 20 of them over a 10-year period. We wrote a couple of papers on it. When I did the literature search, only France had another paper that had 20, but everybody else just had a few. So I don't know why we got a bevy of them for a while, but you have to think about that. And in a young kid, you got to think about atypical mycobacterium too, if it's a lateral abscess, because their immune system's not very good. And if they're playing in the dirt, they're going to get the non-tuberculous mycobacterium. I rarely scope them. If they look sick, you're just going to tip them over the edge. Now, in my training, we had epiglottitis. So we didn't never scope those either because you tip them over the edge and cause airway obstruction, but you'd get a lateral neck. So, I think people still get lateral necks, and I don't think that's a bad thing. It's not that much radiation.
No, I asked, but to be honest with you, when I think about it, I don't think I've ever scoped either for that reason. I always ask because we always think of, potential airway compromise, stridor as a potential presentation, or if they have a URI, maybe they have a little stridor type of sounds. Sometimes it's hard to tell what the sound is,
Oh, for sure.
And so sometimes that can kind of, do I need to do that or not? I think the biggest thing for me in terms of what's difficult, especially with a retropharyngeal abscess, is getting a good exam on like a 3 or 4-year-old. They're sick, they're mad, their neck hurts. I need them to do something for me so I can see if the empiric antibiotics are helping or not. Do you have any, with all of your experience, John? I need you to tell me what is the best way to get a good exam that following morning. Because, usually we round it before the OR at 7, they're barely awake and they hurt, and now it's at 48 hours or whatever, and I need to know, does this need to be drained or not? And I need an exam. What's your process?
It's interesting because you have to think about the consequences of what you do, right? So if you have a kid who's stable, you can have the parents hold them on their lap and hold the arms and head, and you stick a tongue blade in there and just gag them, right, with a light. But if you have an unstable kid, you really don't want to stir them up. There's no reason to. I think it depends if they've had a CT or not, and that'll be a discussion, right? But I think the CT is going to kind of tell you what you need to know. Number one, if they look sick, you probably just need to intervene. I think a CT is important, and I would get a CT that gives you a lot of information without you having to stress them out. Now, just going to the scanner can be potentially dangerous in a kid who's got airway issues. So everybody has to be on board with that. But I don't think you have to push everybody all the time to get like this complete exam. You got to be smart.
Yeah, no, I think that's a great point. I think in terms of like timing of the exam is important. Like it doesn't have to be at 7:30 in the morning or 7 a.m. when the lights are out in the hallway still. And, just because I might have to go back between cases at 9, 8:30 before, depending on how long I've kept them only on clears or whatever we've decided the night before. With mouth opening and gagging for PTAs, if they're feeling better, and I find that if I don't have to use a tongue depressor, and even if I could see their mouth is opening more, compared to
it's better.
like I'm okay with that. Like I don't always have to quote jam it in either. I do find head rotation for retropharyngeal can be, I just have a hard time. Like that's something for me that helps me, because a lot of times some kids will come in looking toxic, but a lot of kids, they're there because the scan showed maybe a centimeter abscess, right? So we're doing IV antibiotics, and granted, we'll get into that, right? Because that size is still not like, 1.8, right? Yeah, like 1.8, then I'm kind of like, ooh, maybe, but maybe not, right? And so sometimes I've even tried like passively, gently trying to turn their head, using light, using toys, using music. And sometimes it can be tough. And and you kind of have to figure out how to make that next clinical decision. And you're right, though, if they're gone to the playroom and they're eating and drinking and happy, then, and maybe they're getting better. And I don't need to force things that don't always contribute to the overall clinical picture.
Yeah. I mean, I think it's, again, being smart, because you get trained to like, oh, you got to do all these things. And, oh, if you don't do it, you're not really completing what you were supposed to do. And I don't think it's always the case. I just think you have to be smart about what you do. You have to get the information you need to make a decision about what you want to do, whether or not you want to treat them with IV antibiotics for a while, whether you want to go to the OR. A lot of that is based on how they look and some of the other parameters. They're going to have blood work that you can look at, hopefully a CT, but that can be a little tricky too on a sick kid. So forcing a kid to do something, I don't always do it. I have to tell you, the parents don't like it. I mean, they look at you like, what are you doing to my kid? I mean, it's shared decision-making, right? But I mean, you're the doctor, so you have to make a decision about what's best for the child and let them know that or talk to them about it.
Yeah, I don't think I appreciated the importance of the relationship you have with the parents and the family, and how much of the history and observations that the parents make when they're with their kid and how important that information is. And talking that it wasn't until probably, not only just at the start of my fellowship, but really when I was started my practice, a couple of the first few years. And even now it's kind of like, there's a certain way in which you have to kind of dance with the parent and the family to kind of help assess this kid and get them through what they're going through.
So when I first started practice, for some reason, sensorineural hearing loss was a big deal. Like, I needed to find craniofacial syndromes, and I needed to make sure every kid, if they had hearing loss, I could diagnose something. So I'm looking at this baby, and they have hearing loss, sensorineural hearing loss, and the eyes are a little wide, I think. And so I'm thinking, I'm kind of talking to the mom. Yeah, your child looks like they have some hypertelorism, and the face looks a little funny. She just looked at me like, who are you? Like, you telling me my beautiful baby looks weird. I never saw her yet. So, I mean, some of it is just being smart about what you're doing. And you can get information in different ways that aren't offensive. Or difficult for the patient or family. Anyway, sorry.
No, it's helpful. So talk to me a little bit about CTs. I feel like most of the time when you get the call from the ER or from the inpatient team, the scan's been done. And at this point, okay, I know there's a retropharyngeal abscess, I know how big, et cetera. But there are a handful of times where I'll get a call, and let's say the child just ate, they have a stiff neck, they have, high white count, there's got fever, there's some fullness, but to get a CT would require sedation, and it's like 2 a.m, and can we just admit them? At that point, when you don't have a CT and you have a quote working diagnosis, how do you manage those kids?
Yeah. I think everything's within reason too. I mean, if they get admitted to 2, it doesn't mean the CT has to be done there. But again, it determines like how sick they are, right? If you have a kid that looks sick and the emergency room physician is worried about him, then that's a different story. If the child looked great, but there are some symptoms, right? Fever, stiff neck, some other concerns, but they're stable. Yeah, I mean, admit them and get the CT in 5 hours or whatever. I mean, we just had a discussion in our group about whether you get a CT at all, because, I mean, so many of these kids respond to IV antibiotics. Do you put them on IV antibiotics for 48 hours? And if they do great, then send them home. The only problem with that is I just got called when I was on call last week, and somebody was looking in the throat, and they said the tonsils look really big, but they'd already got the scan. But when they looked in there, they thought, oh, surely this kid's got an abscess. So if we would have determined, oh, yeah, they probably got an abscess, let's just put them on IV antibiotics because they're stable and swallowing, even though they have a fever and a white count, then that kid would have got admitted to the hospital. But the CT showed no abscess, and it was just tonsillitis. So then the kid can go home. So a CT really shows you how you treat them. So if there's no abscess, the child's swallowing, and they just have, give them a dose of IV antibiotics and give them oral antibiotics and let them go home. If they have a small abscess, less than, 2 to 2.5 centimeters in the medial compartments, medial to the carotid sheath, then they'll probably respond to IV antibiotics. If they're bigger than that, then they probably won't. So you can make determinations with the CT, even though CT is radiation, and that's the argument. You don't want to do it because of radiation, but it's really a good test to kind of guide what you're going to do, because if you don't have to admit them, you're saving a ton of money there. And, for the healthcare system, and plus the child didn't have to get admitted. So
no, those are interesting points, because sometimes I would lean towards giving them a trial of antibiotics, and we're assuming that's what we're treating, and sometimes that can be difficult in terms of counseling and expectations for all the reasons that you just mentioned. Is there ever a role for ultrasound?
I was never a fan, but so I did a little literature search just to see, and it was interesting. I found some article from 1992. It was in like a radiology journal that looked at CT versus ultrasound for retropharyngeal. I guess they went lateral to do the ultrasound, and they thought that ultrasound was better than CT, because CT, if you read all the studies, it's about 75% accurate for whether it's abscess or phlegmon or cellulitis or whatever. I think I've never seen anything else like that, and that's over 30 years ago. So for retropharyngeal, I think it's difficult. Now, if you got some evidence that there's something there, and you did an ultrasound and you wanted to treat them with IV antibiotics, and then, that's probably reasonable to do, especially even for a lateral. But if I'm going to have to take a child to the OR, they're going to need a CT, because I need to know the size of the abscess, the location of the carotid sheath, all those kinds of things. But if a child's relatively stable, even if you have a medial or a lateral abscess, I guess you could go off a ultrasound. And it's interesting because the accuracy is not really mentioned. Of course, I might have missed those studies. It's more of like, oh, we got an ultrasound or CT, and they stay in the hospital the same length of time, and so ultrasound's fine. I'm like, okay, but you're not really telling me if it's accurate or not.
Yeah. I mean, I think they're helpful maybe to evaluate for some of the other things on our differential, PTA potentially, depending on who's doing the ultrasound, and if your hospital's kind of uses that consistently. Lateral neck abscess, most places are pretty consistent and able to help use an ultrasound for that kind of management. Other things on our differential, I think you'd mentioned other head neck abscesses, like parapharyngeal potentially, depending on how big and deep. Although for that, I'd probably still, if we're going to go the OR, want to scan. I think for retropharyngeal, a scan's definitely helpful. But other, parotid, buccal, submandibular, which aren't as common and can be helpful. But even sometimes for those, especially the submandibular space, sometimes I find if we're not moving the right direction, I might still want something anatomical like a CT if we're not moving the right direction for a submandibular space infection, just given the location and some of the other, the submandibular gland and other things that can be there. It's not always a lymph node. It could be an infected lymphatic malformation, ranula, all those kinds of things that kind of change up your management, etiology, and if they're going to need further things down the line. In terms of CT findings for retropharyngeal abscess, you discussed size. You kind of went through it. Talk to me a little bit more about size. What are you looking for? Size, location, other things on your scan that might be red flags or, help you decide OR, not OR.
Yeah. So I'm going to take you through a study we did from 1999 to 2004. Basically, there were like 291 children with neck abscesses over that period of time, with neck infections. Sorry, not all abscesses, but like 195 abscesses and 96 phlegmon kind of cellulitis cases. But during that period of time, we then were starting to give IV antibiotics because we had seen that it was helping even in kids who had greater than a centimeter in diameter abscesses. And we wrote a paper on that like in 2003. And so we had 100 kids that were stable, and we did a trial of IV antibiotics on. And so we looked at if they were successful or failed, and actually 76% improved and 24 of those 100 failed. So then we looked at what are parameters to show whether they improved or not. And it was interesting because there were 55 medial abscesses. So I think of those similarly, retropharyngeal, parapharyngeal, peritonsillar, because 90% of those got better on IV antibiotics. And when you looked at the ones, that size of the ones that improved, it was like 2 by 2.2 by maybe 1.5. So pretty decent sized abscess. That was the average, which means some were smaller, some were bigger that got better. And the ones that failed were bigger than that. And then for the lateral abscesses, we actually had 45 lateral abscesses on what you kind of described, but only 60% got better. And so, and they were smaller when they got better. So they were like 1.2 by 1.5. So here you get this information. So a CT will tell you the location of the abscess and the size of the abscess. So it gives you an idea about potentially who's going to get better. That way, if you have a 3 centimeter abscess and the posterior chain or level 5, it's not going to get better. You might as well just take that kid to the OR. If you have a 3 or 4 centimeter abscess, even if the child's stable in the retropharyngeal area, probably not going to get better. So you may want to go drain it. In fact, I just had a kid come in who had about a 3.5 to 4 centimeter retropharyngeal abscess. He was totally stable. I think he was like 7. I'm like, just give him some antibiotics. And so we did it for 72 hours, didn't get better. And so I drained him. So it kind of held up. And I've been kind of using that data in my head for about 20 years. And it seems to hold up because of the medial abscesses. We only had 3 peritonsillar, which was kind of weird. But it might have been that, 95 of the abscesses, people just took straight to the OR. So there was no trial of IV antibiotics. And so I think the lean would be, if it's peritonsillar, just go drain it. So maybe we didn't have a lot of those, but all of those got better. And they were all big. And over the past 10 years, I have not drained a peritonsillar abscess.
They get better, 100%.
Right.
I think it was Dr. Romain Johnson's, his trial thesis was about PTAs. And
was it?
Yeah, and it was because he did a lot of big data and lots of with different.
He likes big data.
Big data using lots of different databases. It's like statistical, like somersaults. Really, I think it was that he found that 50% will get better, and so I 100% with PTAs. Like I don't, definitely going back to retropharyngeal. Talk to me about like the ones that kind of, I'm like, ooh, I hope the antibiotics work. Are the ones that are like super high up at the skull base? What do you do when those don't get better? Or they're all going to be kind of close to the carotid, but like every once in a while, I think I had read one result where it was like, this carotid course is medially, close proximity. And I'm like, oh gosh, okay, I hope that one gets better too. How do things like that play a role? And what do you do if one of those don't get better? Do you ever what do you do in those situations?
Yeah, so that's a good question, but you bring up a lot of points. So 1995, I'm in my fellowship in DC, and George Zalzal throws up a CT scan of a circular 1.5 centimeter abscess high in the retropharynx. And he goes, John, what do you want to do? I'm like, I just came off a training round. I'm like, let's go drain it. And he said, no. I'm like, why? He's like, John, it will get better. So anyway, so maybe that started my whole thing about IV antibiotics, because that kid did get better. And really, when you look at those high ones, they're usually not that big. I mean, they're usually less than 2 centimeters. So usually those will get better, but the high ones are really tough. And if they don't get better, they'll probably extend a little lower, so it'll give you some access to drain them. But you're right. So, another thing that the CT shows me is the location of the carotid sheath, the location of the carotid to the abscess. So sometimes if a kid doesn't get better, even after 2 or 3 days, I might repeat the CT, because I've seen that change, because it kind of determines, are you going to go medial or lateral? But even if you're going medially and maybe it's gotten a little better, you have to determine the thickness of the soft tissue that you get to the abscess, and then how big the abscess is, right? Because you're going to drain it intraorally, most likely, if the carotid sheath is lateral. But the carotid sheath is still right there. So you want to make sure you know distance, because sometimes you'll stick that 18-gauge needle in and like nothing's coming out. So it's like, then you're in the OR going, what's going on here? Am I in the right place, even though that's where the bulge is? So the CT tells you. So I really kind of look at that and think, okay, well, I've got 5 millimeters, 8 millimeters, whatever, until I get to the abscess because of the swelling of the pharynx. And then the abscess may be 1 centimeter. So if I stick that needle in too far, I'm going to hit the carotid, right? So I need to know those dimensions. And some people might say, well, you're getting another CT. Why are you doing that? I'm like, because I don't want to kill the kid. I mean, I want to make sure that I know what I'm doing. I had this argument one time, probably late 90s, with the head of pediatrics in children's. And it was a lateral abscess and it had erythema. And that was actually one of the signs in our study that shows you're probably going to need to drain it. It's not going to get better on IV antibiotics if you have erythema of the skin on a lateral abscess. That's not retropharyngeal, you're not going to have that. But he's like, look, it's red. Like I said, yeah, but I don't know the extent of it. I don't know where the carotid is. I don't know where any of the any of the vital structures are. I don't know how deep I've got to go once I open it. Yeah, it's great if you just make an incision and it pops right out, but that didn't always happen because sometimes, if it's in levels 2 through 4, it's going to oftentimes be medial to sternocleidomastoid. So you're still going to have to go digging around in there a little bit. And he said, well, you don't need a CT. I think he even canceled the CT I ordered. I'm like, oh, fine. If you don't need a CT, why don't you go drain it?
Right.
I mean, I'm the one who's having to go to the OR and make sure this kid is going to be okay.
Yeah.
So I like information. I don't like any mistakes, right? Nobody does. I mean, we're in medicine. We want to make sure we do the right thing every time as much as we can.
Yeah. And it's good there's important structures all around us in head and neck, but I should have probably asked this in the beginning, but just to clarify terminology, when you say medial and lateral, are we talking in reference to the carotid sheath? Are we talking about intraoral versus external drainage?
Yeah.
SCM, external lateral neck or deep, just so I'm consistent.
Yeah. Right. So that's probably my fault because we were doing this study. I found, if it was medial to the carotid sheath is parapharyngeal, retropharyngeal, and peritonsillar. Lateral to the carotid sheath is levels 1 through 5 and parotid. I guess I found such a big difference in this study. That's kind of how I refer to them because the medial ones usually get better on IV antibiotics and they can be up to 2 centimeters, 2.5 centimeters, which is consistent with the literature. If you look in the literature, there's a couple of different papers that talk about abscesses up to 2.5 centimeters getting better on IV antibiotics. Usually we're talking retropharyngeal and lateral, they just don't. It's not as successful using IV antibiotics. A lot of times you have to drain them. And it's interesting too, because we broke it down by levels 1, 2 through 4, 5, and parotid. None of the parotids got better. In the posterior chain, less than 40% got better. Or no, it was 50% got better. In the submandibular, like you were talking about 45% got better. But in levels 2 through 5, and it could have been based on size, about 80% got better. So, 2 through 4, 80% got better. So it was 45 patients. So it wasn't terrible, but each group, has maybe 5 or 10 or 15 when you're talking lateral, but still it's interesting information to kind of generally guide you about what can happen or what might happen based on how you treat them.
In terms of labs, do you have the pediatricians draw labs, follow labs? I feel like the question I always get asked is, do you want a CRP or an ESR? Probably not the next day, but then I might maybe at 40 hours. I don't know. What are your thoughts on labs? And if so, which ones and how do you utilize them?
I lean pretty heavily on my hospitalist colleagues to admit the patients, and they like data like that, which is fine. So they'll often get like a Ceterate and a CRP when they get admitted. The problem, and those are good parameters. I think the white count's probably even better because I think it changes faster than the CRP, which is probably used more than this Ceterate now. It used to be the Ceterate when CRP came around that they're using that. So I have seen, though, kind of the practice now is they'll admit them to the hospitalist, we'll put them on, depending on the CT, if it's within that range that might get better, and they'll put them on for 48 hours, they'll draw a CRP, and then they'll follow that to see if they're getting better. But what I've seen is even a child that had probably 72 hours of antibiotics and the kid looked great, like I would never think about draining this kid. The CRP had not come down. And so the hospital was just like, yeah, but they're not improving. And I'm like, okay, I'll take them to the OR. Well, I think I got half a cc of bloody, milky nothing. And I don't think I did anything. So I think the CRP lags clinical response. I think I don't know any studies on that. That's just what I've seen clinically. And I think the white count is a good indicator. And then certainly clinically, when they look good, then they're turning the corner. But I have seen people too. So it's interesting because you talk about how long they need to stay in the hospital, where they'll be looking good at like 24 to 36 hours and they'll let them go. And some of those kids bounce back. So I think 48 hours was just generally something we saw. But if you read the literature, that's pretty consistent over the last 2 or 3 decades. That's the benchmark people use, because I think clinically they're seeing that. It's kind of like the studies on chronic tonsillitis. Bluestone and Paradise came up with those numbers, 3, 5, and 7, infections per year or 2 years or 3 years. That wasn't what their data showed. They just said, oh, this seems right. So, I mean, sometimes that's okay.
You got to start from somewhere.
Right. Exactly.
Yeah. Tell me, in terms of empiric antibiotics, I tend, I think of Unison as like the main one. You'd mentioned Staph, and potentially MRSA for younger kids. Do you switch that up and do Clinda? Or, tell me your choice of antibiotics for empirics, and does age matter? Does size, what they've been on outpatient matter to you? How do you decide?
Yeah. So it's interesting, the Unison thing, because that's kind of a new thing. We always put them on Clinda because it's staph and strep, right? And for some reason, early on in my career, probably in my training in the early 90s, I would read these articles about H flu. Sometimes they would find, like I would read all the bacteriology of the abscesses. And so I would put them on Rocephin in addition to Clinda. And I did that, and I saw success with it. But then the hospitalists who were admitting the patients would say, or the infectious disease person say, why are you using Rocephin? Why don't you just use the Clinda? It's going to be staph or strep. I'm like, okay. So during that process, we then sometimes would stop and not do Rocephin, but it would be weird because, and again, I don't have any numbers, but it seemed like some of those wouldn't get better, like half might get better, but the other half wouldn't. So then we'd add the Rocephin and then they would get better. So Rocephin does have some activity against staph and strep, and it may attack it from a different way. So I came to a point in thinking, okay, somebody gets admitted. I mean, how much is an IV antibiotic? Am I really going to create resistant bacteria? They already did that in the 90s because they were giving amoxicillin for every cold. But if I'm only use it on, 100 kids a year or less to add an extra Rocephin, but they seem to get better faster, maybe in my mind, which could be true or not true. So I came to this kind of conclusion, why don't you just put them on both? Maybe they'll get better faster. You can discharge in 48 hours. You're going to save money, and they're going to not have to stay in the hospital. So I think empirically it's staph or strep. And so anything that covers that, certainly Unison covers that too. And so lately, over the past probably 5 to 10 years, people are given Unison. They'll ask me, what do I recommend? And they'll say, we're going to use Unison. I'm like, you're admitting them. You can do whatever you want. So, and then we see, and some of those get better, some don't. They don't get better. Then I've switched to Clinda and Rocephin, and they got better.
Yeah. And you'll usually do 48 hours. And do you ever add steroids? Like I tend to add steroids for all these because in terms of inflammation, decrease, maybe the antibiotics can get to the abscess better if I decrease inflammation, things like that. What are your thoughts on steroids?
So let me ask you, how do you do the steroids? Like, what do you give and how long do you give?
So I will have them do half mg per kg, but there's max doses. Now, granted, this is sort of my own anecdotal, but I'll do half mg per kg and a max of 8 mgs IVQ8. But like, if they're under 5, if they're between they're 2 and 5 years old, we might max between 3 to 4 milligrams. You know what I mean? IVQ8, and then if they're between 5 to 10, depending on how much they weigh. But in that age group, I might max it between 4 and 6 milligrams IVQ8. And I'll probably do that. I'll do at least for 24 hours and plus minus even 48, but usually at least the first 24. Initially, I would say 10 years ago, the hospitals didn't like that because is it masking the infection? Would be one reason. I can't follow their white count would be the second reason. But I find that now I get less pushback, and I think it helps the kids. I don't know. What are your thoughts on steroids?
Who do you give it to? Do you give it kids with cellulitis or phlegmon or abscess? Or there's a certain size that you do?
So if they get admitted and there's a retropharyngeal, for all of it, frankly. Frankly, in the retropharyngeal space, all of it.
So I love steroids. I love them. I think they're great. I think they work wonders for lots of things. I'd tell you, so let me tell you another story. So 1996, I'm a professor at the med school, just starting. So we would cover the adult hospital as well because we weren't that big. Faculty was like 7 or 8 and they needed help. And so I got this call one time I'm in my office and I'm not even supposed to be covering Parkland, which is the adult hospital, the indigent hospital. And Dr. McClay, the secretary said, they need you in OR2 over Parkland. I'm like, I'm not even supposed to be covering. Like, they can't find the other guy. I'm like, okay. So I walk into this room. There's like 17 people in this OR and everybody's like flustered around. And there's this 32-year-old guy on the table, awake, getting versed, and the residents are over the neck trying to do an awake local trach on a guy who had been treated with IV steroids and IV antibiotics for a week in an ICU somewhere. It was a difficult airway. Like, we couldn't get it. They finally got the awake. We did the awake local trach, and then we opened up the neck, and it had a huge pseudoaneurysm that was about to rupture in the neck. And we had 1 inch space next to the skull base. So we clamped the carotid off before this pseudoaneurysm blew and tied it off and thought, I don't know, is this guy going to stroke you? There's no time for a circular Willis test or anything. The guy lived. And so I always think about that with an abscess and steroids. However, 2 caveats, he's an adult and adults are different. And it was a week of steroids. But I'll never forget when I presented that one study, it was like 2001, about neck abscesses and IV antibiotics, and like 10 of the 11 got better. And this guy in the audience who'd just written a paper from Boston on draining all of them, like 80 of them, he said, you know, some of those are abscesses. I'm like, yeah. And he said, you know what's going to happen is somebody's going to sit on somebody out, some kid in nowhere, Ohio, and something bad's going to happen to that kid. I'm like, look, I'm not here to tell you what to do. I'm just here to tell you what we found. But, you know, information is information. So saying all that, steroids and sitting on kids, and it's 2 different things. If you have a big abscess, I use steroids definitely for an initial dose, maybe for a 24-hour period, but usually it's on somebody I'm not worried about at all. And so oftentimes, if they're on IV antibiotics and they're not getting better, I may give a couple doses, but I don't just routinely put everybody on it, except maybe a dose or 2 initially. And I think it depends on the nature of what you're seeing. Like, you know, if there's not an abscess that's going to erode the carotid or something like that, you're probably fine. I mean, because steroids will weaken different structures, different of your body. I think too, it depends on how long they're on them. So that's a little bit of my concern, but 48 hours, you're probably fine. 24, you're for sure fine. It's just if things linger on, you're probably not going to let them linger on that long anyway.
No, it's helpful because you're right. I think the point of sitting on something versus giving them an empiric trial are 2 different things. And so I think that's really important. And 2, I do think, in terms of like, what's it getting you? And you bring up like, well, if it's pretty big and you probably are going to have to train it, still having that dose may be helpful in terms of airway protection, and things like that, if it's middle of the night type of stuff. So it's a tool, but I agree. It's not something that necessarily is a reflex always.
Well, once you drain the abscess, all bets are off. You're fine. Like when we drained them when we were residents, we were draining the peritonsillar. And once the abscess was gone, we didn't worry about it. We gave him some steroids, because now you're taking that risk away of because it's the pressure along with what the steroids can do, so the pressure's off. Because, we saw in our study too, we looked at, like you were talking about, different parameters of size and location, but we also thought, well, gosh, what about if there's pus in the carotid sheath? Because there's some studies that show that may be something concerning. What about if the carotid artery is narrowed? What about if jugular vein is obstructed? So we looked at all that data actually and found that none of it was really inconsequential. Although of the 6 retropharyngeal abscesses that did not improve, 5 had pus in the carotid sheath. So we thought, well, maybe that's something because it approached statistical significance. But when you look at the positive predictive value, 40% that got better on IV antibiotics still had pus in the carotid sheath. So it doesn't really help you determine whether or not you should intervene because a lot of those got better. So I think, we didn't really see anything else necessarily, but you do have to be concerned about a neck abscess. I mean, these are potentially deadly things. And so treating them in a non-traditional approach, and that's become more traditional, but when we were doing it initially, you're putting yourself out there a little bit.
Yeah, that's true. In terms of, let's say you are now, it's the 3-year-old that came in, it's been 48 hours, there's that 1.8 centimeter retropharyngeal abscess, on the right side. Let's say they've been on the Unison for 48 hours and the CRP hasn't really moved because they're going to draw that for you. And you're, exam wise, they've been eating and drinking, but they're not really still doing much with their neck. What do you do next? Those are, because I feel like that's the bulk, right? That's the decision-making tree. That's where we all kind of have to decide sort of, do you give them more time? Do you add more antibiotics? Do you go to the OR?
Well, interestingly, I guess, so going back to the study, out of the 76 that got better, 80% or 60 of them got better or dramatically better or resolved almost by 48 hours. But that still means 20% didn't, but that means they're still potentially going to get better. So I think that 48 to 72 hour window is dealer's choice a lot of times. I mean, kind of depends on what the parents want, kind of what the hospitalist is thinking, and kind of your gut feeling. I mean, you're looking at the kid, does he look sick or is he eating like a champ? I mean, even though his abscess is still kind of big, even though his neck, I mean, you're right. Sometimes that neck pain and stiffness doesn't go away automatically. And that's the last kicker. In fact, that one kid I just told you about where they made me go drain the kid, it was the neck stiffness and the CRP. But otherwise, he looked like a champ. So I probably err on giving him one more day of antibiotics. I mean, after 72 hours, I would think they probably are due to go to the OR. I might rescan him though, because I need to know how big that abscess really is. Is it now 1 centimeter and it was 1.8? So it's going to be harder to find. And so this decreases my risk of doing something bad in the OR.
Yeah. No, I find that's the struggle, like the decision part where I always am like, do I want to give him more time? Do I want to, is there a role to add Clinda or, here? Do you do, most of the time the pediatrician is like, no. And then I'm like, okay, that, maybe that's not going to do anything. And that's just, adding more antibiotics. And so I struggle sometimes with that.
Well, tell them 20% are going to get better if you give them one more day of IV antibiotics.
Maybe that's the better, yeah.
And then if they don't get better, you're like, okay, you call them up.
So I just want to, let's say we do go to the OR and let's say it's that standard, the typical 1.8 centimeter or 2.2, whatever, in between that 1.8 to 2.5 centimeter range. What's your approach usually? Any special tips or tricks, changes that you've made over the years that have helped you with these, or anything that you always do to kind of help you stay safe in the OR?
Yeah, I think staying safe for me is, again, getting the CT and making sure the depth of the pharyngeal swelling and the location of the carotid artery. Because if that carotid artery is medial and the abscess is lateral, you got to go lateral. I mean, there's no other choice. And especially if it's high, it's going to be a little harder. So you just have to buckle in. And if it's smaller, then it's going to be even harder to find, So that's, I guess, I'm so recalcitrant to like a small 1.5 centimeter abscess. It's not getting better. I guess you got to go do something, but it may not be that satisfying in what you're going to get out, but at least, you made the effort. And I remember too, training in the early 90s, like sometimes we take these kids to the OR and we wouldn't get much out, but then they would get better after we operated on them. We thought we were doing something. Maybe we were, or maybe they were just going to get better on because they'd already been on IV antibiotics or something. I don't know. I think, I use a long knife handle blade because I don't want to have to cram my hand in there. And then, I usually use an 11 blade and then, make a vertical incision. But I often will stick a 18 gauge first to try to locate it and just for cultures, and then use a clamp to widen it. It's interesting. So I trained in DC and King Grunfast was there. In the 70s or 80s, he wrote a paper where he stuck a 1/4-inch penrose through the nose, and then he would feed it all the way down to the nasopharynx and the pharynx, and then he would put the 1/4-inch penrose in the actual wound that he made. so that it would stay open for a day or two. But, because you can't just stick it out of the mouth if they're not intubated, so we put it through the nose. And I thought that was kind of interesting. I think a couple of times when we had some extension of a retropharyngeal abscess into the mediastinum, and I was a little more concerned about it because I maybe took a red rubber and put it through the nose and then all the way down and into the actual space. So you could kind of irrigate a little bit too gently. And because it was already, down pretty far into the chest.
Yeah.
And then I think I've probably taken care of several of those, and some of them I would just drain and not do that. I would feed a catheter at the time and suction it out and irrigate it, but I wouldn't always leave like a red rubber catheter. So I don't know if that's necessary or not. I guess it just depends on how you feel about it, how sick the kid is, how worried you are. Art of medicine.
Yeah, no, I've never left anything in the nose down into the retropharyngeal space. Would you sew it?
Well, you could tape it at the nose.
And then, but how do you know it's going to stay in that retropharyngeal space?
You don't. But if it's taped, even if it comes out, you're not going to swallow it.
That's true.
You know what I mean? So, you check on it, I guess. And you don't leave it, for a day or two. And a lot of drains you leave for a day or two and take out anyway. So I think I stopped doing that. I think there was just one really sick kid that we got concerned about.
And for those, so you're right. Every once in a while, they're super sick. It's really big and it goes into the chest. For those, do you ever do an external approach? Or I've had one, it was a tiny baby who had a large retropharyngeal abscess that extended laterally into the lateral neck, as well as into the chest. And we approached it from the neck, and so that we could leave a drain, so that I think the pediatric surgeon because I was like, I don't really want to stick my hands in the, I know it's from the neck, but I'm not trying to go that low into the baby's chest. And so that way she could stick a drain in. Again, those are very rare, but every once in a while.
Right. But like you said, you saw it.
Yeah.
So you got to be prepared and make a decision on it. But I think that's the appropriate thing when it's lateral like that.
Yeah.
When some of it is lateral, you got to go lateral. That's going to protect your carotid, and that's going to give you better extension, like to the danger space, what they say, posterior to the retropharynx even.
But I find those to be difficult too. Like I found that to be a difficult approach because it's inflamed, it's hot, you're going medial to I'm trying really not to get that medial, but you're getting to the close to the big vessels, and I did not enjoy it.
I remember an adult we did when I was a resident that we had to open up both sides of the neck and go from both sides and try to get posterior to the entire trachea, esophagus, over the spine.
Yeah. And I guess the other thing to remember is I think that baby had to go a couple of times, washed out at least more than once. And so I think that's something to keep in mind, that when it's that bad, it's okay that you may have to go back, and it might be part of it. Because I remember there was actually maybe 2 or 3 when I was at Children's for that time period where there were these that had come in, and it required a lot. A lot.
No, I think that's a great point, because for some reason those young kids, maybe it's just their immune system's not great. So you have to drain them, but they're not fighting it as well. So you got to drain them again potentially, especially if they're bad. Nobody's ever going to fault you for taking a kid to the OR. They're only going to fault you if you don't. Something happens, which is the last pearl.
Yeah. No, it's a good pearl. So I wanted to, before we start kind of rounding it out, I wanted to talk to you a little bit about data on cost or length of hospital stay when it comes to draining or doing IV antibiotics. What have you found? What are your thoughts?
So it's interesting because I did look at some of the data, and it's different all around the world, right? Because hospital costs are different all around the world. So when people quote these numbers, it's kind of based on what's happening in their arena, right? So, even Dallas-Fort Worth probably is more expensive than other places to have healthcare, according to what I read in the past. So I think the key for me is knowing the appropriate intervention, whether that's IV antibiotics or surgery, as soon as possible. And then that's going to get them out of the hospital as soon as possible. So it goes back to getting that CT, and is it medial lateral? If it's a big lateral, 2 centimeters or greater, take them to the OR, drain it, put a drain in. You can send them home with a drain and see them back in your clinic. You don't have to keep them in the hospital with a drain in these days, how we used to. But if it's a medial, 1.5 centimeter and abscess, they may get better in 48 hours and they could go home. So you're optimizing the care and the timing of care by increasing your fundamental knowledge of what that abscess actually is. So, if they're sick, you're going to take them to the OR immediately. And when you're just going to treat them for sickness. So I think you just do the right thing for the patient, but using some of the data to determine the optimum kind of timing of care helps decrease the cost in general. And it improves the quality of care.
Yeah, no, that's a great pearl. Having good clinical decision-making early on, like an initial presentation. That's super helpful. John, as we start to round this out, any final pearls or pitfalls, whether it's specific to deep neck, retropharyngeal abscess in kids, any other practice pearls or wisdom that you want to leave us with?
When in doubt, just take them to the OR. Like if you're vacillating about what to do, like I said, nobody's ever gonna fault you for taking them to the OR. But just, have a good fundamental knowledge of how these respond and based on their location and size and other factors. And then you kind of, treat them optimally. Yeah. If somebody's pushing you a little bit to go and you think you're not quite sure or they look kind of sick, just do it. And I'm the guy who treats everything with IV antibiotics. So if I'm saying that, you probably ought to think about it. Because even non-tuberculous mycobacterium, we wrote a study that was medical therapy when standard of care is surgical excision. So,
well, thank you so much, John. Any of our listeners want to reach out to you? Are you on any social media? If you're not, they can also reach out to us and we can get them in touch with you.
I do have a website, John McClay, MD. I don't know if I think there's access to make an appointment. I don't really have social media for healthcare or whatever.
Well, thank you so much. I learned a ton.
Hey, it was great seeing you. It's been so long.
Good to see you too.
All right. Thanks, Gopi.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening and see you next week.